Madam, you are live, good to go.
Yeah. Good morning. This is Dr. Sonal Mehta, Lead Medical Advisor, Intas Pharmaceuticals. As you know, Intas Pharmaceutical is a leading pharma company having strong presence in the fertility business. And being a knowledge partner and commitment to the scientific update and to engage you all during this COVID-19, Intas Women Health, in association with Cooper Surgicals, have organized this webinar. And I welcome you all to this webinar on IUI optimization. Today we have with us three esteemed faculties on this subject, Dr. Rachel Chin, Dr. Rajan Vaidya, and Dr. Rahul Reddy. You all are requested to put your questions through the chat box, and Dr. Rachel will be speaking on best lab practices in optimizing IUI practices. Dr. Rajan Vaid will be speaking on enhancing IUI success and protocol and adjuvants. And Dr. Rahul Reddy will be speaking on evaluation of male factor infertility in optimizing IUI. First, I'll brief about Dr. Rachel. Rachel Chin possesses over 19 years experience in guiding, leading and managing IVF laboratories within the Asian region. She received several Dean List Awards while preparing her bachelor degree, and she obtained her master degree in clinical embryology at the National University of Singapore in 2001. In 2002, Rachel was appointed as chief embryologist in Damansara Fertility Center, and 2013 she became laboratory director for the Reproductive Medicine Center at Kung Ming Medical University. From 2007 onward, she is offering visiting consulting for the IVF laboratory management, training and development in ART and troubleshooting in the labs. Rachel joined Life Global LLC in 2016 as the Asian Clinical Technical Support Manager and later Cooper Surgical Fertility and Genomic Solution. She has keen interest in IVF lab quality control and culture system. With this, I welcome Dr. Rachel to speak on best lab practices in optimizing IUI practice. Over to you, ma'am.
Right. Thank you so much, Dr. Sonal, and thank you so much for Intas Pharma for having me to participate in today's webinar. My topic today is to discuss about best laboratory practices to optimize IUI results. Now, in today's webinar or in today's topic, I will touch on these four main areas, that is regarding IUI in infertility treatment, sperm preparation techniques, the role of sperm preparation media, and the influence of number of multi-sperm inseminated and IUI device. Let's take on with the first topic. Now, we all know IUI now is part of assisted reproduction technique. It's easy to perform, inexpensive, less invasive, and also have a very good couple compliance, low risk of OHSS, and low multiple pregnancy rate. Now, it should be offered as a first choice treatment for couples with unexplained infertility, cervical factor subfertility, psychologic or physiologic sexual dysfunctions, and mild to moderate male subfertility. The clinical outcomes with IUI has been reported, it's around 10.7% in terms of the mean delivery rate per inseminations. However, the variation is very wide. It can be ranging from 4.4 to 19%. And this is based on a study by the French centers, and they look into 7 centers in France. And the reason for these wide variations is because of various issues. It can be because of the infertility causes, the age of the women, the duration of the infertility, and number of multi-sperm would play a role as well. Ovarian stimulation protocol, the GnRH agonist or antagonist, whether it's being used or not when it comes to IUI treatment, the number of inseminated per cycle, as well as the luteal phase support. All this will play a role when it comes to the outcome with IUI. Now, Of course, we all know that just now, as I mentioned, IUI is easy, relatively easy treatments for the patients, and it should be offered for certain patients as a first line. Now, if we want to set up an IUI laboratory, there are areas we have to look into and to consider. Example, the location-wise, yeah? Because what happens is, if we would like to set up an IUI laboratory, we have to look into where it should be located. Ideally, it should be next to a sample collection room, because we prefer not to have the husband or the partner, male partner needs to go back home and to collect the sample and come back to the laboratory and pass the sample to us, because studies have shown that the longer time it takes for us from the moment we collected the sample and from the time we process it will have an impact on the outcome. It's also good to have the procedures room or the IUI laboratory next to the procedure room. Yeah. So again, for the ease of convenience for all the laboratory staff and as well as for the patients. Definitely, it's also part of the laboratory, so it has to be away from pantry, cleaning areas, or common toilet, so that we can cut down in terms of the risk of contaminations. Room space. We need to have a decent space so that we can house all the equipments as well as some consumables, and the laboratory personnel will work comfortably in doing the sperm preparation procedures. We also need to consider, maybe at one point of time, we need to have bigger space, we need to have more equipments because our IUI load has gone up. So all this we have to take into considerations if we want to set up an IUI laboratory. Floor planning is also important, and how it's being planned is also based on the workflow. Everything must be worked smoothly, especially if we have two persons working in the laboratory, so we will not run into each other, accidents will not happen. Other factors to consider when we are doing all this planning is, where should we place all the equipments? Do we have places to put all the consumables? These are all very important because we don't want to have any sort of contaminations in the laboratory. Where are the plugs and switches? Do we need to have the uninterrupted power supply if we are in an area where we have interruptions all the time? And the locations of the door and hatch windows. Hatch window is very good to use when we have the IUI laboratory just next to the sample collections. So once the sample is collected through the hatch window, it can be delivered to the IUI laboratory for processing. Now, other factors, we will definitely talk more later on. But here is some examples of the IUI laboratory. It can be like, example on the left, it can be at one corner, of the room where we house all the equipments, or we have a dedicated room, a small one. We don't need to have a big space. If let's say at the start our IUI load, or we foresee that our IUI load is not so high, you can start off like example, a minimum of 10 meters square, which is quite ideal and comfortable. Now, what about the essential equipments? We have to look into, we must have good quality equipment so that when we do the processing of the sperm and we want to do the assessment of the semen sample, we can get an accurate results. Microscope, we have to get a very good phase contrast compound microscope so that we can see the sperm clearly. We can see on the morphology, motility. If we only get a bright field, which is only good if we do it, use it for the stem cell, we won't be able to see the sperm so nicely. What about the centrifuge? This is also important, especially if we are going to do density gradient to process our sample. And we will touch more in terms of the sperm preparation technique. And we also, if we want to choose a centrifuge, we also have to consider what kind of a rotor we are choosing. Ideally, we should be choosing a swing out rotor, not the fixed rotor. Why? If we look at over here, then you see the reasons. If we are using a swing out rotor to do the centrifugations, we can get a very nice pellet that is seated at the bottom of the tube. However, if we are using the fixed rotor, this will be the problem. The pellet will be just slanted at the side of the tubes, and then if let's say we want to remove the supernatant, we may accidentally remove some of the pellets, which is not nice. Then, of course, we also need to have some device so that it's easy for us to count the sperm. We can use a macular chamber, or we can also use a hemocytometer. Some of the sperm preparation media require us to warm it before we use. So we can have a test tube warmer, a small equipment like this, or if in terms of finance-wise is allowed, we can have a small incubator, but without CO2. So it's more like a non-CO2 incubator for us to warm up our culture media. And most likely, we also would need some of all these pipetters for us to transfer the media or remove the supernatant. Because IUI, when we are handling the semen sample, we should handle it as if it is infectious, it contains infectious diseases. So we have to handle it with care. So ideally, we also should do it in a laminar flow hood, yeah, that is to protect the sample as well as to protect the operator. Now, when we do the sperm preparations, what techniques should we use? Let's discuss on that. But before that, it's also crucial for us to know that when it comes to any consumables that is in contact with the semen sample and the sperm, we have to make sure that it is tested for spermotoxicity, so that it's not going to have any toxicity that can affect the sperm quality later on. It also needs to be tested with endotoxins, and definitely it has to be sterile. Now, there are studies have shown regarding the interval between productions and preparations. How soon do we need to process the sperm once we have received the semen sample? In these studies, by Baidola, it has shown, and also Masura, it has shown that the longer the incubation time, which means the longer the time we leave the sample without doing anything, yeah, we can see that the sperm DNA fragmentations index would have gone up. That means that there are high impact, a great impact on the sperm DNA if we leave it untouched. So it is always ideal if we process the sperm as soon as it's being liquefied, and preferably no longer than 30 minutes. Yeah. And another thing is, it's also crucial during this period of time where we're waiting for the sample to liquefy, we just leave it at the room temperature. And again, the studies have shown that if we put it on the heater stage at 37 degrees, it can compromise the DNA integrity. Now, sperm preparations, definitely all the semen sample we receive, before we do the IUI inseminations, we need to prepare it. We need to process it first. What is the purpose? Is to remove all the seminal fluid, the non-sperm cells, isolate all the morphologically good-looking multi-normal sperm, multi-sperm, definitely. And during the whole process of sperm preparations is also to support capacitation, to prepare the sperm for fertilizations. And at the same time, when we are doing all this process, we are also removing sperm with DNA fragmentations. In terms of sperm preparation techniques, the common use would be the density gradient and the swim-up method. Now, WHO have given some guidance in terms of choices, which types of the sperm preparations to be used. It can be sperm washings, swim-up, or the density gradient that I mentioned, but all have the pros and cons. Sperm washings is not highly recommended, mainly because it does not remove any non-viable sperm cell. In fact, it's just spinning all the sample and then pellet it down, whether it's more viable or non-viable cell. Therefore, there is an increased risk of reactive oxygen species formations if we do a sperm washing alone. In terms of the swim up, it's a very simple technique. It's easy to use. We don't need to do any centrifugations. We need only, yes, we still need to do, correct me, sorry about that. We still need to do a centrifugations to wash it one time. And again, we put the media layer over the pellet and then we do a swim up, yeah. Yes, we can get a very high percentage of multi-sperm doing this simple swim up. And it's only best if we use it for ejaculates with high sperm count and motility. However, it also have studies have shown by doing just a swim up alone, in terms of the DNA fragmentations, if we do a comparison with the density gradient, it is still contain relatively high sperm with the sperm DNA fragmentations. Density gradient is a technique used to separate cells by their density. At the moment, many studies have shown that it is the best and the most optimal method to process the sperm for IUI. Mainly because during the whole process of doing density gradient, we are not only able to remove the non-viable cell, but we also selecting the motile and also good morphology sperm with a very high DNA integrity. And during the whole process as well, it generates less reactive oxygen species. This is provided if we control the centrifugation speed carefully. So in this way, of all this technique, density gradient seems to be the best technique to use. Now, here is a study to show, to compare in terms of the sperm DNA between fresh sample, which means it's not being processed at all, wash sample, just like what I mentioned just now, it's just a simple washed technique, a swim up, a density gradient, as well as density gradient plus a swim up. So in these studies, if we look into the chart over here, we can see that sperm DNA fragmentation is vastly reduced if we do a density gradient or even density gradients with swim up. Not just that, in these studies also look into the post-processing evaluations 24 hours later. So what they do is they also look into the processed sperm via this few ways technique. After 24 hours, look into the sperm DNA fragmentations as well as sperm motility. So what they found out is the sperm DNA fragmentations, even after 24 hours, is still at the lowest. However, sperm motility is still maintained as high at 84% if we compare to only density gradient alone or the swim up. So from here, it also gives us a very clear signal that density gradient plus a swim up would be the ideal way for us to process our sperm. Here is another study to look into to compare density gradient, swim up, and unprocessed sperm. So what they do is they look into the sperm telomere length, because sperm telomere length is also a sign about sperm or male factor infertility. For men with subfertility issue due to male factor, their sperm telomere length is much shorter. Now, over here, again, look into all this technique, unprocessed sperm, density gradient sperm, and also swim up sperm. Look into sperm telomere length, DNA fragmentation index, the ROS generations, and the progressive motility. Now, what happened is, again, we can see that in all these charts, density gradients give us the best results in terms of protecting, having a more good quality sperm with more intact DNA. As well as in terms of the ROS generations, this is over here, this chart, you can see that the ROS generations, if we are using the density gradient, is the lowest. In a way, also it protects the sperm. What about after we process the sperm? Now we know that, okay, once we get the sample, we have to process as soon as possible, as soon as it's liquefied, preferably within 30 minutes. Then in terms of preparing the sperm, processing the sperm, density gradient is the best. And if we can have density gradient, after that follow up with a swim up, it's even better. Now, what about after we get the sperm, after we have processed the sample? How soon do we need to use it? How soon do we need to do the IUI inseminations? Will that have an impact on the result as well? Well, in these studies, it shows that yes, there is. Yeah. So if, let's say, after we have processed the sample and then we don't use it, we just incubate it for a period of time before we use it, they will have an impact on the sperm again. Not just again this time, it will cause DNA fragmentation, especially if during this period of incubations, we put it at 37 degrees. Therefore, it's always recommended if, let's say, we have processed the sperm, Don't put it at the process sample. That's what I'm trying to say. The process sample, it's ideal not to put it at 37 degrees. We just put it at room temperature would do. And in terms of the interval between preparation and use, yes, the longer it is, the greatest harm it would be to the sperm. But there's no clear consensus yet as of when is the so-called best interval time. The ideal is as soon as it has been processed and is ready to be inseminated. So the moment, let's say we have got the sample ready, processed, within 30 minutes, have it inseminated is the best. Because again, during the whole process of inseminations or during the whole process of the sperm processing, the sperm has gone through again a cascade of events to sort of like gain the capacity for fertilization. The active hyperactivation process, the capacitations process is all happening during the sperm preparations that period of time. So again, we do not want the sperm to be sort of like exhausted if, let's say, we waited for too long before we use it for IUI inseminations. So use it as soon as it's ready. Now, what about the sperm preparation media? Does it have a role? Can we use any media for the preparations? Now, why we want to do the sperm preparations? Of course, just now, like we say, it's actually to prepare the sperm to remove the non-viable samples or the sperm from, and then we can sort of like harvest all the good morphology, good motility sperm for us to use for IUI inseminations. But on top of that, the sperm itself have to also acquire fertilization potential during whole this process. Yeah, that is in terms of capacitations, acrosome reactions, so that it can be fertilizing the oocytes. Now, how or what will happen during this period of time? It's not just the sperm processing alone to help, the sperm to gain all this capacity to fertilize the oocytes, but the media itself and the conditions during that time when we process the sperm also will have an impact. Also, sort of like will help the sperm to gain all this fertilizations capacity. Now, one thing we have to bear in mind, sperm prefer conditions that is totally different from oocytes. Now, from the oocytes, we are very focusing in terms of the pH. Make sure of the media of the pH is around 7.2 to 7.4. However, for the sperm, it is different. Sperm, especially the processed sperm or the sperm or spermatozoa alone, it's actually prefer a more alkaline pH. The main reason is because a more alkaline pH will actually cause an increase of the internal pH of the sperm or the spermatozoa. And this will help to increase the calcium concentration within the sperm and help the hyperactivated motility of the sperm. This is actually very crucial. And here again, is in the studies have shown that if, let's say, we culture the spermatozoa or we put the spermatozoa in a media of 7.4 or 8.5, a more alkaline situations, we can see that when in terms of the hyperactivations, as you can see over here, is much higher if, let's say, the media of the pH is at its more alkaline versus at 7.4. Now, another things inside the sperm preparation media that is also crucial for the sperm. Why we keep on talking about sperm DNA fragmentations, why we keep on talking that the sperm needs to have a good DNA integrity to be used for IUI inseminations, because that again will affect the oocytes later on and the embryo. Because if spermatozoa with high DNA fragmentations, again, it's either unable to fertilize the oocytes or potentially the embryos would get poor quality, or even the patient, if they manage to get pregnant, will have a high miscarriage rate. That is why we do our very best to protect the sperm DNA. And one of the things that always, sort of like harmful for the oocytes or for the sperm, in this case, is the ROS, reactive oxygen species. And this is the culprit that can cause high DNA fragmentations. That is why in all the sperm preparation media, we put a lot of attention into it. Make sure that you have antioxidant properties inside to protect the sperm from the ROS. And what are the example of antioxidants? EDTA, taurine citrate. So if let's say we use media without all these antioxidants properties inside that media, and again, we are not protecting the sperm at all. So it is crucial at any media that we use, we have to look into what is the component inside the culture media. Is it have anything that is protecting the sperm that we are going to use for the IUI later on? Yeah. So this is again very, very crucial. Now, as I mentioned, a good sperm media or a good medium actually not just supports, but actually also to protect the sperm. To protect the sperm, again, all the all the ROS have the antioxidant properties. And during that period of time when we process the sperm, help the sperm to get all the fertilization's capacity, being able to capacitated, being able to go through the acrosome reactions, so that it can fertilize the oocytes later on after we do the IUI inseminations. But at the same time, we also need the media to provide energy to the sperm. This is very, very important. So that is why choosing a right media to use will help us a lot, yeah, in terms of getting a high IUI success rate. Now, as I mentioned just now, if we want to use any sperm media, make sure it is a good media that can help and support. Look into the components of the media that we use, whether it contains all these important features or not, to help the sperm to gain the whatever that is needed for it to be able to fertilize the oocytes later on. Now, final topic area I will touch on for today, it's regarding the influence. Now we know that how to process the sperm, all right? We know that, oh, we need to use a very good quality sperm, good media to protect the sperm during the whole process. Now, what about the influence of the number of motile sperm?
Dr. Rachel, we are running short of time. Can you quickly complete? Yeah.
Sure. We have another 2 slides actually. So finally, it's in terms of the number of motile sperm. What is the number that is ideal to be used? So again, here is studies. It depends also a little bit on the sperm, what do you call that? The morphology of the sperm. If let's say the sperm morphology, it's a little bit low, then again, ideally, we need to use a high concentrations of the sperm. And over here, the studies have shown that a minimum of 5 million motile sperm, when the normal morphology of the sperm is less than 30%, it has to be used. But the general consensus is at least 1 million. Now, finally, it's regarding the IUI device. You know, type of the catheter and used to do the IUI is also very crucial. If we can do it under the ultrasound guidance, it will help us to see how much we have inserted into the uterine cavity. And a soft tip catheter definitely will help because it can cause less destructions on the endometrium compared to the hard tip catheter. As you can see over here, like this is an example, a very good soft tip Wallace catheter. And you can see that in terms of the opening is at the side of the catheter, so that it's easier, you know, for the sperm. So when we dispense the sperm. Now, in summary, good IUI laboratory setup is very, very important. Have to have a proper planning, right equipment, and also consumable. Density gradient with serum would select sperm with high DNA integrity and high motility rate. Use media that supports sperm function and protects from oxidative damage. And finally, soft tip IUI can cause less trauma to the endometrium, and that should be the first choice. Thank you. Oh, by the way, I'm here leaving a selected bibliography for anyone that would like to know more of all this data I've quoted just now in my presentations. Thank you.
Thank you, Rachel, for a very insightful lecture and clarity on the subject. There are some questions to you.
Sure.
Yeah, many of them are asking protocol for sperm preparation. Does it differ in COVID positive cases?
Right. At the moment, there's still a lot of uncertainty when it comes to COVID-19. Yeah. So what happened is we always have to treat all the samples now as if it is actually contagious. We just have to be careful. It's just like doing the example, say the HIV positive patients, you know, and for HIV positive, we have shown that density gradient is the best technique to use on that. But when it comes to COVID-19, we're still not 100% clear yet when it comes to the semen sample, whether it will have the coronavirus inside. So I think at this point of time, I may not be in the best place to advise what is the best technique to use. Yeah, so because we're all still learning about it, about this virus at all. Yeah.
Thanks. How much IUI catheter contribute to IUI results if someone is using low quality IUI catheter?
It's actually very good questions. In terms of the Cochrane review, it has shown that maybe in terms of the types of catheter used, whether it's a soft tip or maybe it's a very rigid catheter, it will not affect in terms of the pregnancy result. This is from the Cochrane review of all the studies. But having said that, you know, if let's say we can use a soft catheter during the inseminations that have less destructions in the endometrium, definitely it would be much better. And in terms of the patient comfort wise, it is also much better to comply versus using a hard tip sort of like catheter to use. So for me, in my laboratory last time, we always use a soft tip catheter, and it's actually good compliance, easy to use. And in terms of the results wise, especially it's not bloody at all after we do the inseminations. That is also very, very important. So we were happy using a soft tip catheter.
Right. Is there any role of microfluidic fluidic chip for IUI procedures?
Sorry, the line was a little bit breaking just now. I didn't catch your questions.
Microfluidic chip in
Yes.
IUI procedure.
Microfluidic chip, the chip. That one I'm not very familiar. I'm sorry. So probably I will not be able to answer that questions.
How to increase sperm morphology?
I think this is $1 million questions. Everybody would like to increase the sperm morphology, but I think this is also very, very difficult because again, if we look into the trend of the worldwide now, the sperm morphologies, it seems to be decreasing. Yeah, from the previous editions of the WH of 15-20%, now it's based on 44% of the sperm morphology. But I suppose for the men, I think a lot of the time they have to look into their sort of like lifestyle and diet. Yeah, we all know that in terms of if they have a poor diet and also in terms of lifestyle, they like to smoke a lot. Yeah, and unhealthy lifestyle in terms of, you know, not keeping up with a good diet and maybe have underlying problem in terms of hypertension and all this. They make medications that take. All this will have an impact on the sperm morphology. So I suppose if one person really want to improve, start off with a healthy lifestyle. I think that is one way, but it's not again guaranteed that would really improve a lot when it comes to sort of like improving a person's sperm morphology.
Right. Adding fructose or pentoxifylline in the wash media, can it help in increasing motility of sperms?
Right. Yes, pentoxifylline, all this has been used, especially for sperm, example, in IVF, not so much on the IUI. Yeah. So when it comes to the IVF inseminations or, you know, sperm whereby they have very, very poor motility. So there have been, there are people using pentoxifylline, yeah, to help, you know, at least to select some motile sperm to be used for IVF inseminations or for ICSI. But however, all this so-called chemical where we add into the sperm preparation media is only for a short period of time. Again, people have seen that if we add on pentoxifylline, you will see that the sperm motility will go up, but it's only for a short period of time. And again, so it will go down. You know, it's just to boost the sperm for that short period of time. It doesn't really help in terms of a long term. So I suppose if you really want to use, unfortunately, you want the sperm is really poor and we only have IUI options for this couple. Now, If you want to use pentoxifylline, yes, you can, but make sure after you have sort of like introduced pentoxifylline into your sample, do the insemination as soon as possible.
I see many questions and all of them are complimenting to you for very good presentation. I'll take only one or two questions now. Is CO2 incubator needed for IUI?
Right, no. That is, in terms of CO2 incubators, you don't need a CO2 incubator. The main reason is all the sperm preparation media, most of them are Hippe's buffer media, right? When it's a Hippe's buffer media, as long as we warm it up, it can be used without the CO2 incubations. If we put it, the media containing Hippe's, and if we put it inside the CO2 incubator, the interaction between the Hippe's and CO2 will cause the media to be very acidic. That is really not favorable for the sperm. Yeah. So if you want to use the media, no CO2, either you put it at 37 degrees or at room temperature. As I mentioned just now, sperm actually prefer more alkaline pH. So remember that, not acidic, but alkaline.
Right. What is the optimal RPM and time for DGC method?
What is the optimal?
Is the optimal RPM and time for DGC method?
Right. The optimal is 300 G in terms of the speed of the centrifugations, right? 15 to 20 minutes. Do not do the centrifugations for a long period of time, or if you're short of time, you want to rush, use a high centrifugation speed. You increase it, say, to 500 G for, let's say, 5 minutes. I've seen people doing that. We are not doing any help to the sperm at all. In fact, we are damaging the sperm if we are using a very high centrifugation speed. Because during this period of time with a high force, it's actually causing damage to the sperm, damage to the DNA. Whereas at around 300 G, it has been shown proven safe for the sperm. So the high recommendations is 300 G maximum, that is the maximum speed, 15 to 20 minutes doing the density gradient. Yes.
Thank you. Which catheter is better, one having side opening or opening at the tip?
Okay. Now, this is again, it's more a little bit on the preference. The main reason is the design of having the side opening is just the concept to think that, well, this is the fallopian tube. So if let's say we have the opening, so the sperm, the dispersion of the sperm, it's going to the so-called tube is potentially easier rather than going straight, which is going to the fundus and the sperm would swim. Now, there's no studies to show that which one is more preferable or would give us a best result or better result, higher pregnancy rate. There's no studies on that. But I suppose either one is actually good, no harm. So you can use either the side opening or it's just opening at the tip.
How we can decrease the sperm DNA fragmentation by sperm preparation?
Right. If we want to reduce the sperm DNA fragmentations, one thing is the best is to use the density gradient method, that is again where we select the sperm that we want to use for IUI. Those are the sperm without any DNA fragmentations. Those are the sperm with good DNA integrity. That is one thing we want to do. Another thing is during the whole process, make sure that when we handle it at room temperature. Like I mentioned just now, once we receive the sample, once it's liquefied, process the sperm as soon as possible, the semen sample as soon as possible within 30 minutes. Then during the whole process as well, make sure that we do density gradient and then make sure that the media, preferably room temperature. Then after processing, if unfortunately we cannot do the inseminations immediately, we have to wait, maybe 30 minutes, 40 minutes. During this period of time, just leave the processed sample at room temperature rather than put it at 37 degrees. All these little steps will actually help to protect the sperm.
Right. There are many people are asking, we keep semen at 37 degree temperature, but you asked to keep it at room temperature.
Yes. The main reason is because the semen sample itself, it contains the seminal plasma plus a lot of other things inside there. And all this is actually causing harm to the sperm if we leave it at 37 degree and not touch, So it's, yes, we put it, let's say, on a heated stage and 37 degree, you will notice that the liquefaction is faster, no doubt about it. But if we put it at the room temperature, it will get liquefied anyway within, say, 10 or 15 minutes. Yeah. So during this period of time, it is actually highly advocated we just put it at room temperature. Don't put it at 37 degree, because after all, what we want to do is to protect the sperm. And studies have shown that if we put it, the whole semen sample at 37 degree, the sperm, the damage is done on the sperm is much greater than if we put it at room temperature.
Thank you, ma'am. Last question, what is the best pH of sperm washed media? Does it vary as per the pH of the semen sample?
Yes, the best media to use, they have been shown that the studies have shown that how favorable sperm is for a more alkaline pH. Yeah, so the pH of the media for the sperm, if possible, is a more alkaline one, is more favorable than the pH at around 7.4. Yeah, because we have known that for the sperm wise, we need to have a higher or I should say a lower pH, a more alkaline pH to induce the influx of the calcium to go inside the sperm to cause the hyperactivation for it to fertilize the oocytes. So for sperm wise, it's different from oocytes. Sperm prefer a more alkaline environment. Yeah, whereas the oocytes prefer 7.2 to 7.4.
Yes. Thank you, ma'am. With this, we are concluding. I am getting so many questions, but due to constraint of time, again from Intas, we thank you for giving us time.
You're most welcome. I should stop sharing now, yeah?
Yeah.
Okay.
Our next speaker is Dr. Rajan Vaidya. He is the eminent faculty from Mumbai. He is honorary consultant and head of the Department of Assisted Reproductive Technology at the Nauroji Vadia IVF Center, Parel, Mumbai. Postgraduate teacher in ART, Maharashtra State University, Health Sciences, Maharashtra, international and national faculty at ART conferences. He has his own centers at Kalyan, and he is the peer reviewer of Journal of Human Reproduction and Embryology, and he is member of FOXY, MOGS, ESHRE, ASRM, Aspire, IMA, IAG, and he is a life member of ISAR. He is the patron member Thane Obstetric Gynec Society. He is the eminent teacher of postgraduate medical OBGYN doctors. With this, I welcome Dr. Rajan. He will be speaking on evaluation of, he will be speaking on enhancing IUI success and protocol and adjuvants. Over to you, sir, Dr. Rajan Vaidya.
Thanks for the kind introduction, Dr. Sonal. Myself, Dr. Rajan Vaidya, and I'll be speaking to you on the clinical aspects of best practices to optimize the IUI results. Next slide. Next. Intrauterine insemination, as you all know, involves the deposition of concentrated pellet of motile sperms into the uterine cavity around the time of ovulation. Reason for achieving higher pregnancy rate is the presence of large number of highly motile spermatozoa close to the site of oocyte fertilization. Sperm preparation leads to removal of leukocytes, dead sperms, which generate free oxygen radicals, as Rachel just now told you, which are detrimental to the functioning capacity of the sperms. Next slide. Intrauterine insemination is the first line of assisted reproduction method, and that is least expensive and most effective. The overall success rate are quoted to be anywhere around 10 to 20% per attempt, and cumulative pregnancy rate for 3 attempts is ranging between 30 to 45%. Next slide. Indications: anovulatory infertility and unexplained infertility form the major chunk of indications. 50%, almost 50% of the patients coming to you or for whom you will counsel IUI would be belonging to anovulatory infertility, particularly PCOD, and the unexplained infertility forming next 40%. The remaining 10% would be due to male infertility, male subfertility, about which Dr. Rahul Reddy will be talking to you in detail. And then you have mild to moderate endometriosis, occasional donor sperm inseminations, sexual dysfunctions, frozen samples, cervical factors, etc., etc. But I'll be speaking mainly on anovulatory infertility and unexplained infertility. Next slide. Contraindications, some of the contraindications I have listed here: cervicitis, endometritis, bilateral tubal obstruction, obviously, and most severe cases of oligospermia. Next slide. There is certain pre-IUI workup necessary, basic tests to assess the general health of the patient, and there are certain fertility tests to assess the fertility of the patient. So most importantly, you should ascertain the thyroid status of the patient to rule out any thyroid disorders, and prolactin levels should be estimated to rule out hyperprolactinemia. Tubal patency has to be confirmed by some sort of tubal patency test, and my test of choice is saline infusion sonography, which we have been doing for more than 2 decades now. About the fertility tests, the two most important tests which I would like to tell you of the ovarian reserve tests are anti-Mullerian hormone and day 2 antral follicle count. Anti-Mullerian hormone, as we all know, can be done on any day of the menstrual cycle. It is virtually a walk-in test. It can be done, it has least intracycle variability, and has a very high predictivity as far as the ovarian response is concerned. Baseline antral follicle count confirmed by transvaginal sonography on day 2 or day 3 of the menstrual cycle has an added advantage that its results are instantaneous and it is more cycle specific. So I lay more faith in antral follicle count if it comes to comparison between AFC and AMH. Next slide. Ovarian reserve tests are important to prognosticate the outcome of the IUI cycle specific to that patient in that particular cycle. So helps you in counseling regarding the chances of success. And these are also important to formulate the starting dose and maintenance dose of gonadotropins in gonadotropins only IUI cycles. As I already said, tubal patency has to be established by procedures like saline infusion sonography. Next slide. Just skip this slide. This is comparison between AMH and AFC, and all of us know it very well. Next slide. Though we say that AMH has no intracycle or intracycle variations, there are certain biological, environmental, reproductive, and lifestyle factors that affect AMH. And for example, prolonged use of OCP, current pregnancy, history of ovarian surgery, endometriosis, whether operated or not, current smoking, chemotherapy, and low vitamin D levels all decrease, whereas PCOS tends to increase the AMH levels. Next slide. What are the aims of controlled ovarian stimulation in IUI? There are several aims. One is to recruit a uniform cohort of follicles, to get up to maximum two good quality oocytes, to prevent premature LH surge, to avoid ovarian hyperstimulation syndrome at all costs. The last thing that you would like to have in your IVF center or ART center is ovarian hyperstimulation syndrome, to get a perfect endometrium, to get an optimal pregnancy rate, and in an Indian scenario particularly, it should be cost effective. Next slide. Why do we stimulate the ovaries? In a normogonadotropic, normovulatory patient, why do you want an ovarian stimulation? This is to ensure the adequate number of oocytes. Two, it may correct subtle ovulatory disorders and to ensure more precise time to ovulation and thereby plan insemination. Next slide. Next. So define the patient population, which I already said. PCOS, about 50%, 40% patients will be unexplained infertility, and the remaining 10% from the male subfertility and other category. Next slide. So I'll be talking to you on PCOS first, though I must tell you right at the beginning that American Society of Reproductive Medicine has proposed, the practice committee has proposed significant changes for management of unexplained infertility through Fertility Study Journal, which is their mouthpiece journal, in the latest issue of February 2020. I'll be taking up unexplained infertility later. Let us first talk about IUI in PCOS. Among the oral ovulation, clomiphene citrate, the age-old ones, being in clinical use since 1967, it's indicated in anovulatory or oligovulatory cycles, unexplained infertility. It induces ovulation by increasing gonadotropin secretion from the pituitary in response to blockage of estrogen receptors at the level of hypothalamus. Next slide. Fortunately, the contraindications are few: ovarian cyst more than 3 centimeters on the baseline scan, current active liver disease, hypogonadotropic hypogonadism, as well as hypergonadotropic hypogonadism. Next slide. There are certain prerequisites before starting clomiphene citrate. Thyroid function test should be normal, serum prolactin should be normal, normal or near normal male factor, progesterone withdrawal bleeding must be present, adrenal function should be normal, and as I said, tubal factor must be evaluated and should be normal. Next slide. This is the most important slide, one of the important slide of my presentation, how to use clomiphene citrate. It can be started on day 2, day 3, day 4, or day 5, but I start it on day 2 because clomiphene has both agonistic as well as anti-peripheral anti-estrogenic effects on the particularly endometrial lining as well as vaginal lining. So the earlier you start in the follicular phase, less is the anti-estrogenic effect on the endometrium. Typical starting dose in my practice is 100 milligrams, though you can start it at 50 milligrams but never exceed more than 150 milligrams because then the results start dropping. So I started on day 2 or day 3 of the menstrual cycles, do follow-up transvaginal scans on day 8, 10, and 12 to find out the number of follicles and the size of the follicles which are developing. And by normally around day 12, the lead follicle, I always aim to have 2 to 3 follicles. When the lead follicle has reached 18 millimeter in diameter, we give HCG trigger and follow it up with IUI 38 to 42 hours later. This is how an ideal clomiphene citrate cycle for IUI should go. Next slide. TVS, transvaginal sonographic monitoring for ovarian stimulation, is mandatory to estimate the size and number of the developing follicles to detect ovulation. And if the response is excessive, it has to be, it helps us to rule out the possibility of ovarian hyperstimulation syndrome, to rule out the higher order multiple pregnancy rates, and also to monitor the endometrial thickness. So remember, whenever there is a clomiphene citrate cycle going on for IUI, transvaginal strict ultrasound monitoring is absolutely mandatory. Next slide. How many oocytes do we require? How many follicles do we require to get an optimal pregnancy? This is a very wonderful meta-analysis of 11,599 patients. And this was published in the Journal of Human Reproduction. It's a mouthpiece journal of European Society. And it says, since in cycles with more than 3 or 4 follicles, the multiple pregnancy rate increased without substantial gain in the live birth rate, IUI with controlled ovarian hyperstimulation should not aim for more than 2 follicles. Next slide. Same thing here, Middle East Fertility Society reiterating the same thing 5 years after what was proposed by Journal of Human Reproduction. Aim for just 2 mature follicles. Next slide. I would like to draw your attention to 2 important. I described you the ideal cycle of clomiphene citrate, how should it proceed. But as we all know, in medicine, the things do not proceed the ideal way always. I would like to draw your attention to the 2 important scenarios that occur not very infrequently during the clomiphene citrate inductions. And first of this is that you find that on day 10 scan, the lead follicle is restricted in growth as compared to day 8 scan. That means there is no further growth. In this case, 2 investigations are absolutely mandatory, and that is serum LH and serum prolactin. Serum LH more than 10 international units not only has sealed the fate of the follicle, but it has sealed the fate of that entire cycle, because this means premature luteinization has already occurred, and the premature luteinization affects oocyte quality as well as endometrial receptivity. This patient should be counseled to undergo GnRH antagonist cycle in addition to clomiphene citrate in the subsequent cycles. Serum prolactin more than 30 nanograms per ml implies treatment with cabergoline. The follicular growth will then resume after starting cabergoline. Cabergoline must be discontinued at the evidence of ovulation because we do require normal functioning corpus luteum post-ovulation to sustain the luteal phase. These are the patients where baseline serum prolactin was normal. But with the once you administer clomiphene citrate, once the gonadotropin start coming down, even the prolactin starts getting secreted. And these are the patients typically called as spikers. Spikers means their serum prolactin starts spiking once the gonadotropin start coming down. Give them cabergoline treatment and you will get wonderful results. Next slide. Next slide. Next slide. Next slide. In the second scenario, no, just go behind. Just go behind. In the second scenario, yeah, this is the correct one. In the second scenario, you find that even though the endometrium has, the follicle has reached 18 millimeter, the endometrium is lagging behind, say around 7 millimeter or less. This is due to anti-estrogenic effect of clomiphene citrate directly on the endometrium. No amount of exogenously administered estrogen is going to improve it. Next slide. Please be at next slide. Yeah, thank you. Please be there. Slide showing no association of endometrium. In this scenario, there is no need to cancel the cycle. This is a wonderful slide which shows no association of pregnancy rate for endometria between 7 millimeter to 14 millimeter in thickness. In case the endometrium thickness is less than 7 millimeter, you have to counsel the patient that the pregnancy rate, say for example, instead of being at 20%, it would come down to 10%, but still there is no need to cancel the cycle. Next slide. I have included just one slide on not only endometrial thickness, but subendometrial and endometrial blood flow also is an important factor. I can speak for about 15 minutes on this, but just one slide. It is important to remember that along with endometrial thickness, the assessment of endometrial and subendometrial blood flow is equally important as a predictive factor for successful implantation. Next slide. So for the patients who have thin endometrium at the time of ovulation, that is when the follicle is matured, this was one of the most wonderful paper published by Kozer and others in the archives of gynecology and obstetrics in 2014. This is known as luteal phase clomiphene citrate for ovulation induction in women with thin endometrium at the time of ovulation. We give medroxyprogesterone in this protocol. We give medroxyprogesterone acetate for 10 milligram for 5 days, and at the end of the last tablet, after the last tablet has been taken, immediately the next day we start with clomiphene citrate without waiting for the menstruation to occur. Eventually she will menstruate, but since you have started the clomiphene citrate in the luteal phase, there will be longer follicular phase available where there will be no influence of clomiphene citrate, because other clomiphene citrate levels will be less. This paper showed that it improves the endometrial thickness, gets serum better serum estradiol levels, and better pregnancy rates. So this protocol is particularly useful for patients, or rather women, who have endometrial thickness less than 7 millimeter on the day of trigger in the previous cycle. Next slide. When should IUI be withheld? IUI should be withheld when there are more than 2 dominant follicles more than 18 millimeter, or more than 2 dominant, there is 1 dominant follicle only, but there are more than 15 millimeter 5 follicles that are there. You should withhold the IUI, because if in these patients there is a chance of developing ovarian hyperstimulation syndrome. Next slide. How many cycles of, this is a very important question, how many cycles of clomiphene citrate with IUI? Maximum pregnancy rate, I would like all of you to please remember that maximum pregnancy rate in clomiphene citrate IUI cycle occurs in the first cycle itself, and that is around 50%. And the cumulative pregnancy rate for 3 cycles is around 75 to 80%. After 3 consecutive clomiphene citrate cycles, the pregnancy rates start drastically dropping down. So therefore, in a young patients with age less than 35 years, maximum 3 cycles of clomiphene citrate with IUI. For those patients with more than 35 years, maximum 2 cycles of clomiphene citrate with IUI. And this was a wonderful paper published by Dove and others in Fertility Sterility Journal of December 2008. That is almost 12 years ago. Wonderful paper. Next slide. This is what we were doing till 2014. Induction with clomiphene citrate even for PCOS patient till. In 2014, this was a landmark paper published by Richard Legros in the New England Journal of Medicine. What did it say? It was a trial of letrozole versus clomiphene citrate for infertility in the polycystic ovary syndrome, Richard Legros and others. And it concluded As compared with clomiphene, letrozole was associated with higher live birth rates, ovulation rates among the infertile women with polycystic ovarian syndrome. And since then, in my practice, letrozole is the drug of first choice for ovulation induction in patients with polycystic ovarian disease. And I believe it must be so with many fertility consultants. Next slide. What are the potential advantages of letrozole over clomiphene cited in polycystic ovarian PCOS patients? A high rate of monofollicular development, which reduces the risk of multiple pregnancies. No direct anti-estrogen effect on the peripheral tissues like endometrium. So the endometrial thickness is not affected. A much shorter half-life compared to clomiphene citrate and lower serum estradiol levels. Here, I would like to little digress from the topic. Since we are on letrozole, I do a lot of work on oncofertility. That is, we do fertility preservation for estrogen receptor positive breast cancer patients and early endometrial cancer patients, who are all endometrial cancer patients are estrogen receptor positive. And in those random start stimulation protocol, we precede the stimulation protocol with 48 hours prior by using letrozole. It's such a wonderful drug that in doses as low as 5 milligram, it achieves 97% reduction of serum estradiol. There we titrate the serum estradiol levels to less than 500 picograms every day, and it does not affect the oocyte quality, oocyte number, and quality of the oocytes. At the same time, it does not exacerbate the original malignancy or the resected malignancy. So in ER positive breast cancer patients, this is the protocol of choice where we precede our random start stimulation protocol 48 hours prior with letrozole 5 milligram. Next slide. When you consider whenever you consider even the combination treatment, say letrozole with metformin or letrozole clomiphene with metformin, letrozole with metformin gives much better results in PCOS patients than clomiphene citrate with metformin. Next slide. What about sequential controlled ovarian hyperstimulation? That is combination of oral ovulagens and injectable ovulagens. Again, you see whether it is a CC followed by HMG or letrozole followed by HMG. Letrozole followed by HMG gives much better pregnancy rates, and letrozole followed by HMG is the lot superior combination. It's the protocol of my choice when I consider sequential or combination ovulagens. Next slide. The entire yardstick of success in all assisted reproduction technique procedures has shifted from just having a successful implantation about a decade and a half ago. We used to consider successful implantation as successful, to now single normal term infant without any multiple pregnancies. So this is how the yardstick of success has changed. And this is where letrozole scores very heavily over clomiphene citrate, as it leads to monofollicular development and aversion of multiple pregnancies and averts the multiple pregnancies. Yes, next slide. So to summarize, since letrozole has the highest monofollicular growth rate, we recommend this as the drug of first choice for infertile women undergoing ovulation induction and IUI in women with polycystic ovarian syndrome or polycystic ovarian disease rather. Next slide. Now coming to gonadotropins only for ovulation induction in PCOS. There are cases where you find these are CC, clomiphene resistant and letrozole resistant patients where we may have to resort to gonadotropin only for ovulation induction. A very careful counseling is required even before you initiate the treatment. The counseling must involve that in case of a hyper response, we have two options. We'll have to either cancel the cycle for the fear of having higher order multiple pregnancy or ovarian hyperstimulation syndrome, or we may have to convert your IUI cycle into IVF cycle, in which case we will not be transferring the embryos in the index cycle, we'll be freezing the embryos and we'll be transferring them at a later date, which will give you 3 to 4 times higher success rate. But this has to be forecounseled, not when the patient is already through into the cycle and have received 4 to 5 injections. And then you tell her that she will have to spend more for IVF cycle. She may be economically distressed. I must tell you, friends, the entire assisted reproduction treatment heavily rests on realistic counseling. It is easier for the patient to accept the modality of treatment. It is easier for you to face the patient in case the results are negative. So proper counseling is required. The traditional protocol used to be a step-down protocol where we used to start FSH in the doses of 150 or maybe one lesser than that, depending on the BMI. Then on day 7, we scan the patient, titrate the doses according to the sizes and the number of follicles, optimize for 2 or 3 follicles. At when the leading follicle reaches 18 millimeter in size, give the ovulating 17 millimeter in size in gonadotropin, give the ovulating dose of HCG and carry out IUI 38 to 42 hours. But this step down protocol had a high cancellation rate, anything between 10 to 25%. So the next slide. The protocol of my choice and protocol which most of the fertility consultant must be following now is for PCOS patient, chronic low dose step up protocol using recombinant FSH only. Chronic low dose step up protocol using recombinant FSH, it works the best. Why recombinant FSH? Because I would not like to have any trace of LH activity in my gonadotropin. According to me, it should be the protocol of choice. We start in these patients a dose normally around 50 milligram, but you can even go lower. That is 37.5, 37 no, milligram, 50 IU, not even that, 37.5 IU in a lean PCO. Give it for about 10 to 14 days. Can we go for the next slide? Yeah. Increase it by say about 10 to 40, give it for 10 to 14 days. Scan her around 14 days. You will still find that not a single follicle has reached about 14 millimeter. Double that starting dose. So if it was 37.5, make it 75. If it was 50, make it 100. Scanner again on day 21, you will definitely see a follicle which has crossed 14 millimeter. Continue the dose. When it reaches 17 millimeter, give the trigger with HCG 10,000. Carry out the IUI at 38 to 42 hours. You will get a wonderful pregnancy rate, say around 25 to 30%, with less chances of, almost zero chances of ovarian hyperstimulation syndrome, very low chances of multiple pregnancy. And this has been the protocol of my choice. What the principle of this protocol is, the FSH threshold has to be reached gradually, which reduces the risk of excessive stimulation. The main objection to this protocol, this was prior to the advent of pen devices, that it might lead to, and it did used to wastage of gonadotropins and frequent visits to the hospital, titration difficulties when there are fractionated doses like 37.5 IU or 112.5 IU. But with the advent of multi-dose pen devices, it is easy to calibrate those given fractionated doses, self-administer them, and therefore it has eased out. More importantly, and very important point, the prices of recombinant FSH have been scaled down to just minimally over the highly purified FSH. So all in all, everything is working well for chronic low-dose step-up protocol as a protocol of choice for patients with polycystic ovarian disease. Next slide. Next slide. Next slide. This is a repetition of what I already said. Next slide. This is a wonderful paper published again in Journal of Human Reproduction in 2015, low-dose HMG versus clomiphene citrate. We can clearly see that the pregnancy rates have doubled when you use low-dose chronic step-up protocol versus clomiphene citrate. This was a randomized control trial, so it's a level A evidence. Next slide. The pros and cons, I have already spoken about this. Next slide. One more question. I have already almost selected all practical questions that have been asked to me during my various talks at various places. Daily versus alternate injections. I would always request all of you to give daily injections and not to cut down the cost by giving alternate injections, because steady levels of gonadotropins have to be maintained if you have to sustain a proper follicular growth. You may find this follicle appearing good if you go alternate injections, but it ultimately undermine the pregnancy rate. So daily injections is the rule. Next slide. Aversion of premature LH surge. The very famous paper of Balan et al. In 2001 showed that the incidence of premature LH surge is around 25% in patients of polycystic ovarian disease. Therefore, it is strongly recommended, and premature LH surge, as we have already seen, affects oocyte quality, affects endometrial receptivity. Therefore, it is strongly recommended to use GnRH antagonists in polycystic ovarian PCOD patients, gonadotropin-only cycles. Next slide. Gonadotropin antagonist, addition of gonadotropin antagonist eliminates LH surge, allows conversion of IUI to IVF cycle in case it is necessary, It allows programming of IUI cycles. You can avoid weekend IUIs. I'll tell you in a couple of slides more how do we avoid weekend IUIs. And the dose is either ganirelix or cetrorelix, 0.25 milligrams subcutaneously when the lead follicle reaches 14 millimeter in size. Next slide. This is the diagram of typical antagonist protocol. We start HMG or recombinant FSH, whatever is, there is no difference here. And start on day 2. Once the lead follicle reaches 14 millimeter in size, add antagonist. When the lead follicle reaches about 17 to 18 millimeter, give a triggering dose of HCG, typically 10,000 international units, and carry out IUI about 38 to 48 hours after the trigger. Next slide. This is what I have already described, whatever the slide mentioned. Yeah. How do you avoid doing IUIs at the weekends? Say, for example, the follicular growth occurs in such a way that on Friday the follicle has already matured and you are due to give the injection, which will mean the IUI will be on Sunday morning. So what we will do what do we do in our clinic is, on that Friday, we give half of the dose of the gonadotropin, give antagonist, call her on Saturday morning. On Saturday morning, we do not give her gonadotropin, give her only antagonist. And around 4 p.m. or so, we give a triggering dose of HCG to carry out IUI 40 to 42 hours later. That is on Monday morning between 9 and 11 a.m. So addition of antagonist gives you that little play of 24 hours to avoid IUIs at weekends. Next slide. This is a wonderful meta-analysis by Lee and others, which shows that GnRH antagonist reduces the incidence of premature LH surge and increases the clinical pregnancy rate when used in controlled ovarian stimulation IUI cycles. Next slide. So advantages of antagonists I have already enumerated. It gives higher pregnancy rate, allows coasting, avoids ovarian hyperstimulation syndrome or cycle cancellations. Next slide. More commonly asked questions to me again. What should be the IUI timing in relation to HCG trigger, or whether we should be doing single IUI or double IUI? Next slide. If you get 3 facts well understood. Number 1, ovulation always occurs 36 to 40 hours after the triggering dose. Number 2, oocyte when ovulated, that is when released from the ovarian environment, is fertilizable only for the period of 12 to 16 hours after the ovulation. And number 3, as Dr. Rachel stated, the sperm when prepared is already capacitated, and that capacitated sperm retains its fertilization potential only for 2 hours. When you get all the 3 facts right, you automatically get the answer. The answer is single IUI 40 to 42 hours after the trigger gives you the best pregnancy rate, and there are many papers to show that single IUI done 40 to 42 hours after the trigger gives you the best pregnancy rate. So if you get your basics right, you get the answers automatically. Next slide. Now coming to the luteal phase support, clomiphene citrate cycles do not require luteal phase support, as we all know, but all the other cycles, whether gonadotropin or letrozole cycles, it is mandatory to give luteal phase support. But that luteal phase support in IUI cycle need not be as aggressive as IVF cycles, because in IVF cycles you have sucked all the follicle, including the granulosa cells, and all the corporeal lutea lying there are devoid of any granulosa cells, and you have to do a total progesterone supplement. Whereas in IUI cycles you have a functioning corpus luteum, so maximum 400 milligram per day, that is for about 200 milligram BD intravaginally. It could be either suppository or a gel or a pessary or a spray. All are bioequivalent. We have done bioequivalent studies at our Vadia IVF center about the modes of delivery of progesterone transvaginally. All are bioequivalent, and no preparation is superior to the other. Next slide. And then this was another landmark presentation which was presented in the ESHRE at Spain, Barcelona in 2000. We were all eagerly waiting for this result. You all must have already understood. This is results of the Lotus 3 trial. Those were announced in the ESHRE at Barcelona in 2018 and published subsequently in the Journal of Human Reproduction. What does it state? Oral dydrogesterone has the similar efficacy to the safety of as efficacious and safe as micronized vaginal progesterone with the ease and convenience of oral administration. So oral dydrogesterone, many working women find it very, in the doses of 30 milligram per day, that is 10 milligram 3 times a day. Many working women find it very convenient to take because vaginal medications, they find it little cumbersome, particularly to use during their working hours. There is a very important caveat, precondition to the use of oral dydrogesterone, and it is the woman or the patient must have a functioning corpus luteum for oral dydrogesterone to succeed. So it can be given for all IUI cycles. We have got the corpus luteum there. It can be given in all IVF cycles where fresh embryos transfers are contemplated. So index cycle transfers, you can give it, but it cannot be given for frozen embryo transfer cycle patients or oocyte donation cycle patients or embryo donation cycle patients. A functioning corpus luteum presence is a basic prerequisite for oral dydrogesterone treatment. Next slide. Avoiding complications. Two important complications must be avoided at all costs. That is ovarian hyperstimulation syndrome and multiple pregnancy. Next slide. To be a OHSS free clinic should be the aim of every reproduction center, be it IUI or IVF. In IVF cycles, we already achieve it by resorting to antagonist protocol, agonist trickle, freeze the embryos and transfer them in the subsequent cycles. But wherever the index cycle transfers are also contemplated, in my unit, in my private setup, we transfer not more than single blastocyst for patients less than 35 and 2 blastocysts for patients more than 35. Of course, there are other determinants apart from age that will determine the number of embryos to be transferred, but I would not go into that because that is not the topic of today. In IUI cycles also, one must aim to have maximum 2 follicles to be aimed at the time of trigger, so that to at least avoid higher order multiple pregnancies and polycystic ovarian disease. Next slide. Avoiding multiple pregnancies. Multiple pregnancies should be avoided at all costs, as there is a higher risk of perinatal morbidity, mortality due to higher incidence of preterm deliveries. I would consider it if with IUI, if you give triplet pregnancy or quadruplet pregnancy, I will consider it as a failure of IUI treatment, rather than success. In IUI treatments also, at the most, 2 follicles should be aimed at. As I said, the entire yardstick of success has shifted from having a successful implantation to single normal term infant delivery.
Sorry to interrupt, sir.
Having not more than 2 follicles, and
we are running short of time.
Should be the of choice. Next slide. A couple of more slides. What leads to this? Again, an important paper in 2004. What leads to higher incidence of multiple pregnancy? Is it IVF or non-IVF? Both in Europe and US, the paper coincidentally came in 2004. The maximum number of multiple pregnancies, including higher order multiple pregnancies, accrue by virtue of non-IVF cycles, that is IUI cycles. So it is very imperative to aim for 2 follicles. Next slide. Very important changes advocated by American Society Practice Committee in the management of unexplained infertility, and we'll see what are they. Next slide. Next, yeah, IUI natural cycle versus stimulated cycle. Summary statement says there is a strong evidence that IUI in unstimulated cycle is much less effective than stimulated cycle, and therefore it is not recommended to perform IUI in natural cycles for the treatment of unexplained infertility. The level of evidence is grade A. Incidentally, this was our paper which was published by one of my fellow at one of our annual conference somewhere in 2015. We had a prospective randomized control trial of 100 patients with 50 in each arm, and where we matched them for unstimulated cycle versus stimulated cycle and proved that IUI in stimulated cycle gives 3 to 4 times higher pregnancy rate. Next slide. This is a very important take-home message for all practicing gynecologists. Time intercourse with clomiphene citrate or letrozole with ovarian stimulation should not be advocated. It is not recommended to use clomiphene citrate or letrozole for ovarian stimulation and leave them to timed intercourse. It does not lead to higher pregnancy rate in cases of unexplained infertility. Next slide. Again, ovarian stimulation with gonadotropin alone and leaving them to natural intercourse does not lead to higher pregnancy rate. Next slide. So what works? IUI with oral ovulogenics, that is clomiphene citrate or aromatase inhibitors. Here there is a strong evidence that IUI with clomiphene citrate or aromatase inhibitor, that is letrozole, has a higher pregnancy rate, and that therefore it is strongly recommended that in a case of IUI, in a case of unexplained infertility, 3 cycles of either CC or aromatase inhibitor, whatever be the choice or whatever is determined by the ovarian reserve test. For 3 cycles for patients less than 35, 2 cycles for patients more than 35. If there is no pregnancy, this couple must be counseled to undergo IVF treatment. Next slide. Again, combination treatment does not prove to be superior. It's only the oral, which is a very wonderful guidelines by American Society of Reproductive Medicine, published in their very recent issue of February 2020. Next slide. So what is the effectiveness of IUI versus IVF efficacy? In couples with unexplained infertility and men with a total motile sperm count of more than 10 million and a good chance of pregnancy, at least 3 cycles of IUI with ovarian stimulation, either with clomiphene citrate or letrozole, is the most effective option, published in the Journal of Human Reproduction somewhere in August 2020. Next slide. IUI for male factor infertility. I leave this entire topic to my next co-faculty who will talk to you in much detail. Next slide. Success rates of IUI depend on the indication and of course type of procedure, etc. But overall, anovulatory infertility around 21%, unexplained infertility around 15%, and male factor, depending on the severity of the male factor, 10 to 14%. This success rate help you to counsel the patient about the realistic expectations of the treatment of IUI. This help you to counsel them better. It helps them to adopt the line of treatment better, and it helps you to face the patients better in case the results are negative. Next slide. And with that, I come to conclusion of my presentation. Thanks for logging in and watching me or listening to me. I would be happy to take the questions at the end of the next session. Thank you, Dr. Sonal, and thank everybody for listening to me very patiently. Thank you very much.
Thank you, sir, for giving us very insightful and covering all the practical and clinical aspects of IUI, right from the basics, evaluation, and the protocols. Thank you from on behalf of Intas as well as from all the viewers. We will take the questions after the next session is completed.
Okay.
With this, I welcome Dr. Rahul Reddy. Dr. Rahul Reddy is a consultant microsurgical uroenterologist with immense experience and skills. He has fellowship in andrology and men's health, director Androcare Andrology Institute, consultant microsurgical andrologist at Continental Hospital, Hyderabad, Infertility Institute, Secunderabad, Nova IUI, Hyderabad, OSS Fertility, Hyderabad. There are so many list of hospitals where he's a consultant andrologist. His area of special interest is microsurgeries for azoospermia, sexual dysfunction, and he has to his credit many awards and achievement. Best Junior Surgeon Award 2010-11. Vaidya Ratna Award 2015-17, Best Andrologist Award from the Worldwide Health Care Awards 2015, Pratibha Puraskar 2016, and so many. With this, I welcome Dr. Rahul Reddy to speak on male subfertility optimization before IUI. Over to you, sir.
Yeah. Good morning, doctors. We heard other two speakers talking about sperm preparation for IUI and how to treat a female before starting IUI. But what is important is most of us, we miss the other part, because even the sperm quality and the count is almost important, because the 50% of success rate lies with a better quality sperm. So now let us see how to optimize a male, subfertile male before IUI. So normally what we do is we just do semen analysis. We think semen sperm count is good, and we start doing IUIs. Sometimes we do IUIs with very less sperm count. But my suggestion is, let us start with male factor workup. We'll give at least 2 months time for the male to improve his sperm quality, then plan IUI. Because the success rate of IUI always depends on the sperm quality. Because there was another question which says how to improve sperm morphology. Then we have to give enough time for the male to improve his semen quality. See, sometimes we may not improve the morphology, but most of the times, if you change his lifestyle and if you can treat their underlying cause, we can improve the morphology. So why male factor workup is important? Let us see the two case scenarios. Here, 29 years old female, she had history of recurrent early pregnancy loss. Early pregnancy loss in the sense first 12 weeks. She had 4 IUIs and 1 IVF, all are failure. Later, when husband semen analysis was done, all his semen analysis reports, previous semen analysis reports were normal, but every report showed pyospermia. So his semen culture was positive and his sperm DNA fragmentation was 56. So this is the cause for all those IUI failures, IVF failures. The cause is high DFI because of seminal infection. So now this shows why it is important to treat a male before doing all these procedures. And second case scenario, we had a 34 years old male patient. His semen analysis for asthenoteratospermia. A couple underwent 6 IUIs and 1 ICSI. After that, everything was failure. They came for evaluation. Again, simple thing is all his semen analysis reports showed pyospermia. And semen culture, we did semen culture, it was positive. His DNA fragmentation was 62%. So after that, once we treated his seminal infection, they had natural inception. So we all know that nowadays male factor is more than 50%. If you see all the semen analysis which are done in good labs or IVF centers, most of the report says teratospermia, that means abnormal morphology. So more than 50% of the males, they're having problem. We can correct them. So how to treat them? So most common question which is asked is, doctor, what is treatment for oligoasthenoteratospermia? See, oligoasthenoteratospermia, it's not a disease. It's not a diagnosis. It's like a phenomenon. It's like fever. There is some underlying cause for all these things. It can be infection. It can be genetic. It can be hormonal imbalance. It can be varicocele. So we have to treat the underlying cause. And it's simple. It doesn't take much time. Maximum time it may take is 2 to 3 months. So these are the common environmental or lifestyle factors which affect male infertility. So one is increased testicular temperature. That means people who are obese, who has excessive thigh fat, or who are constantly sitting for 7 to 8 hours. There is increased testicular temperature. So we had to advise these males to avoid increase of testicular temperature. They have to wear loose undergarment. Sometimes, if they are continuously sitting, moving around once in an hour will help them in decreasing testicular temperature. Smoking, alcohol, radiation exposure, stress, lack of exercise, all these things can affect male infertility. So how to evaluate an infertile male? So one is history, clinical examination, semen analysis, hormonal evaluation, radiological evaluation, and cultures. Advanced tests I don't recommend in most of the patients. So now history, what is important if you are planning for an IUI is recent history of illness. If there is recent history of fever or any kind of illness or urinary tract infections, better to wait for 4 to 8 weeks, let the sperm factors recover, then plan for IUI. So semen analysis, so WHO, this is according to WHO guideline, a new guide, 2010 guideline. It's almost 10 years, but most of the in India, most of the diagnostic centers, they are not following this guideline. They are still with the older guidelines. So now, according to this, the count should be more than 15 millions. And motility, we had so many confusions in motility, rapid progressive, slow progressive. Now all of them have been taken out. Now it's only progressive motility. If it is more than 32%, then it is normal. Morphology, it can vary depending on where the semen analysis is done. If it is most of the IVF centers or andrology centers, they follow WHO guidelines. So morphology, the WHO guideline is strict criteria. So always it is less than 4%. So we have to don't compare morphology done in diagnostic centers with IVF centers, because in most of the diagnostic centers, they give morphology as 70% or 80%. But in IVF centers, it is on the lower side because we follow a different guideline. So when you're planning for an IUI, first thing is you have to rule out semen collection problem, because most of the times we get referrals on the day of IUI saying that, doctor, today we have planned for IUI, but this patient is not able to give semen sample. So first thing we have to see is whether this patient has any semen collection problem. If there is semen collection problem, you can use a vibrator in the center, or if problem is severe, because most of the males on the day of IUI, they have clinic ejaculation. That means in the clinics, they can't give semen analysis, or out of stress on that particular day, they can't give semen analysis. Collect the semen sample and freeze it, and you can use it on the day of IUI. And so apart from, generally what we do when we are planning for IUI, we just see count, motility and morphology. But apart from them, they are all important, but apart from them, there are other macroscopic evaluation, which gives us diagnostic information about the sperm, like appearance, odor, liquefaction, volume, viscosity, and pH. Why these are important? First, let us see about value. If you see a semen sample with good count, motility and morphology, but volume is on the lower side, that means there is either hormonal imbalance, that means low testosterone, or there is a partial blockage at the level of ejaculatory duct, or some infection. So now, without doing improving this semen volume, don't plan for IUI. So it is very simple. So because lower semen volume cannot neutralize vaginal acidity, and with a small volume, it's difficult for us to do IUI also. So if testosterone is on the lower side, we can put them on gonadotropins or clomiphene citrate. If there is infection, we can treat the infection. Same time, liquefaction issues. If a semen sample is showing persistent delayed liquefaction or very high viscosity, then it can be because of prostatic infections. So we have to treat that and give them a lot of zinc. Zinc is a natural antibiotic, works on prostate. So after 2 months, we can plan for IUI. So, and coming to hormonal evaluation, like how you evaluate a female with hormones, all these males with oligospermia have to be evaluated with hormones. That two important hormones, what has to be done is FSH and testosterone. If testosterone is too low, repeat testosterone, LH and prolactin levels. And if patient is obese, overweight and chronic alcoholics, then along with testosterone, you have to do estradiol. So now, why testosterone is important? Testosterone promotes growth, differentiation, functioning of accessory organs of reproduction. That is why the volume is on the lower side if testosterone is on the lower side. And testosterone has a role in maintenance of normal reproductive function in adults. And testosterone stimulates transport and delivery of sperm, and testosterone increases sexual drive in both males and females. So what has to be done? All these males with low testosterone, we have to increase their testosterone levels. So testosterone level, ideally it is around, it should be around, for young male, around 30 years, it should be around 4 nanograms per deciliters. So if it is on the lower side, then I'll come to that treatment part later. Second thing, when you are seeing a case of recurrent early pregnancy loss, then always think of male factor. Even at least in some patients, you will find out some reason, either infection. In our study, what we did at AndroCare, most common cause of recurrent male cause of recurrent pregnancy loss is seminal infections. So, and it leads to high ROAS, high DNA fragmentation, and it leads to early pregnancy loss. So now these are the common causes, male factors for recurrent pregnancy loss: advanced age, chromosomal. Anyway, chromosomal, nothing can be done, but DNA fragmentation, we can do something to decrease DNA fragmentation. sperm aneuploidy. So these are the papers which says, which shows the role of male factor in recurrent pregnancy loss. So now, what should be done? Now, if you are seeing a a couple of recurrent early pregnancy loss, so doing an DNA fragmentation test is expensive. So for all patients, is it mandatory to do a DNA fragmentation test? I say no, because it is expensive, and there are not many labs which do proper DNA fragmentation tests. And so simple thing, you have to rule out treatable causes of high DNA fragmentation. That is like increased testicular temperature, infections, and varicocele. So we have to look for those things. So out of them, easiest thing is clinical examination for varicocele. And so why I'm saying clinical examination is, if it is grade 3 varicocele, then only it is important. It is not subclinical varicocele or grade 1 or grade 2 varicocele, which can cause high DNA fragmentation. That can coexist, because most of the patients with high DNA fragmentation, if there is grade 1 varicocele, that is not the cause. It is just coexisting varicocele, but that is not the cause. We have to look for other cause. So here, semen culture, in our study, we are coming out with a paper, because most of the international publications, they don't recommend semen culture, but for Indian population, what we have found is most common cause of high DNA fragmentation is seminal infection. So do a simple semen culture. Semen culture should be automated culture, not manual culture, because now most of the good diagnostic centers, they are doing automated culture. We call it as Vitek2 culture. If it is positive, treat the patient, and if it is, then if necessary, then you can do a DNA fragmentation test. Because doing a DNA fragmentation test, again repeating DNA fragmentation test after a month to check whether it has come down or not, it becomes an expensive affair. So that is why we don't recommend sperm DNA fragmentation as a routine investigation. Look for other alternatives. So semen culture, no guidelines says about semen culture as a routine investigation. But if there is recurrent early pregnancy loss or pyospermia, because pyospermia is different from bacteriospermia. If in spite of seeing pyospermia, if semen culture is negative, then it's not infection. Pyospermia can be because of urethritis also. So now what we have to give importance to bacteriospermia, not pyospermia. Pyospermia may be an indicator to check for infection. So these are the indications for semen culture. If there is persistent pyospermia with impaired motility, or persistent delayed liquefaction in the semen, low volume ejaculate with normal testosterone. That means when you see a patient with low volume ejaculate, urotestosterone, it is normal. Then you have to look for accessory gland infection. So it can be seminal vasculitis or prostatitis. And low fertilization rates or bad quality embryos in IVF, repeated abortions or repeated early pregnancy loss. All these cases, just do semen culture one. So coming to medical management, so we have specific therapies and non-specific therapies. In specific therapies, we have treatment of genital tract infection, endocrine disorders, and ejaculatory disorders. And non-specific, and we have antioxidants and aromatase inhibitors. Now, how to start management? Management always starts with evaluation and proper diagnosis. We have to get a diagnosis, which is very important. There are only 2-3 tests, one hormonal test, one semen culture, one total Doppler. If you can't examine the patient, will tell us about the diagnosis. So, and medical management, we have 3 common types of medical management. All patients anyway, we start them on antioxidant. Antioxidants will decrease ROS levels, will help in increasing sperm motility and morphology. But if you treat the underlying cause, without treating underlying cause, these antioxidants may not work. So underlying cause like varicocele or hormonal management or infections, we have to correct them first. So coming to hormonal management, so the common treatments what we give is clomiphene citrate, but what I say is this is not for everyone. We are not supposed to give clomiphene citrate for every male with oligospermia, because if it is a testicular failure where there is high FSH, it may not help this patient. In fact, it is detrimental to the patient. So clomiphene citrate has to be given for patients where when FSH is on the lower side, then you can give clomiphene citrate, because clomiphene citrate, if you put them on 25 milligrams of clomiphene citrate for a month, it should be okay. But more than that, it impairs testosterone to estradiol ratio. So then TE ratio becomes abnormal, and patient comes back with abnormal lower sexual desire, because as estradiol value increases, it negatively affects the sperm quality. So tamoxifen can be given for everybody. It's a good drug, not much of side effects. So if FSH is on the higher side, you can put them on tamoxifen 10 milligrams BD. Anastrozole and letrozole only in obese patients with abnormal, it's spelling mistake, abnormal TE ratio. It is not for everybody. Only if there is an obese male with low testosterone and high estradiol value, you can put them on anastrozole and letrozole. Even that, initially I start daily doses, later I put them on alternate doses, because for males, even alternate doses works. For maintenance, once the TE ratio stabilizes, you can even put them on weekly once doses. And gonadotropins, these are the main treatment, state treatment for these patients. So if testosterone, if you find a male with low testosterone, put him on HCG injections. HCG injection, 5,000 international units once in a week for 4 to 6 weeks. Then repeat testosterone and estradiol. If estradiol is on the higher side, put them on add letrozole or anastrozole to that. Continue HCG injections. But if testosterone is in the normal range after 1 month and estradiol is normal, then you don't have to give these injections. 1 month should be more than enough. But if testosterone is low, estradiol is high, then you have to continue this medication. As I said, antioxidants, medical management of oxidative stress related infertility. One is lifestyle modification, smoking, dietary habits has to be changed, alcohol has to be stopped, weight loss is important. So sometimes weight loss may take long time, but regular exercise at least help them in decreasing ROS levels, and avoid activities hitting the scrotum, and treatment of infections and varicocele. So coming to micronutrients. So now see, all the medications, instead of calling them as antioxidants, most of them are micronutrients. So these micronutrients, they are involved in successful maturation of the sperm, provides nutrition for the motility of sperm. They help in improvement of sperm count and motility. They help in production of sex hormones. They prevent sperm damage. But these medications has to be given for at least for 60 to 70 days, because sperm cycle is around 74 days. So you have to put them on at least 2.5 months. Ideally, it should be 2.5 months medication, or at least 2 months medication. Then you can plan for IUI. Varicocele, as I said, if it is only clinically palpable varicocele or grade 3 varicocele, then it has to be operated. Otherwise, subclinical varicoceles, there is no need to operate. And there are new recommendations. If semen parameters, all the semen parameters are normal, but DNA fragmentation is on the higher side, then also we can operate. But here we have to rule out other causes of high DNA fragmentation, because this may not be the cause for high DNA fragmentation. You have to rule out other things like increased total temperature. That means if we see an obese patient with varicocele, even if you operate, there may not be improvement because of his excess increased testicular temperature. The positive effect may not be there. And if there is persistent decrease in testicular size, then we have to operate these varicoceles. So coming to my last slide, this is take home message. All these male patients, they need proper history and clinical examination. Rule out erectile dysfunction and ejaculatory dysfunction in these males, because sometimes infertility may be because of erectile dysfunction. most of the people with erectile dysfunction, they have to plan their intercourse. So what they do is they take one tablet in a week and then they plan intercourse on that particular day. So that may be the main cause for infertility. So we have to treat their erectile dysfunction. And semen analysis, always repeat, do a semen analysis in good quality lab, or send your technician for proper training in semen analysis. And apart from motility, morphology, and the concentration, give importance to volume and liquefaction. And hormonal assessment is must. If when in doubt, we do scrotal Doppler and transrectal ultrasound. Transrectal ultrasound is for patients with persistent low volume ejaculate and persistent hyospermia. And there are certain don'ts in male infertility. As I said, clomiphene citrate is not for everybody. It has some side effects, and there is no role for direct testosterone injections. So don't put them on direct testosterone injections, because direct testosterone injections like Sustanon, Serenose, they suppress HPT axis and they may cause azoospermia. And multiple antioxidants or micronutrients. Don't put these males on multiple brands of antioxidants. One brand once daily or twice daily should be enough based on their problem. And varicocele ligation for subclinical varicoceles, ultrasound detected grade 1, grade 2 varicoceles, surgery is not necessary. Thank you, doctors.
For giving us a very insightful, practical, and taking us from case scenario to its solutions, and giving us crystal clear take-home messages. Thank you, Dr. Reddy. Now we will have some questions to you as well as to Sir Dr. Rajan. There are so many questions, but we are already running short of time, so I will be taking few of them. There is one question to Dr. Rajan. How to optimize IUI in endometriosis grade 1? Sir?
Hello.
Hello, sir.
Yeah. How to optimize IUI in endometriosis grade 1?
Yes, sir.
Yeah, endometriosis is just one of the factors. It all will depend upon the overall fertility parameters of the patient. It will depend on the age of the patient, the ovarian reserve test, the results of the ovarian reserve test. Presuming everything is okay, and endometriosis, the question specifically stated grade 1 patient, grade 1 endometriosis, right?
Yes, sir.
Yeah, my choice of treatment in that case, if the ovarian reserve tests indicate normal, male factor is normal, then in that case, my choice still would be first clomiphene citrate and then carrying out IUI the traditional way which I said.
Correct, sir. There is a question for Dr. Rahul. Sir, how long will you give HCG injection in hypo males after correction of testosterone? And when do you prefer testosterone injection in such male with hypo?
Hypo, it may take months. Ideal treatment, a minimum treatment should be at least 6 months. Initially, we start with HCG injections. HCG injections to improve testosterone levels. HCG injections here, it may not be like a regular patient where we give weekly injections. Here, there we have to give higher doses with the frequency should be on the higher side. So generally, what we do is HCG 5000 weekly twice for 1 month. Then we do repeat testosterone. If testosterone is on higher side, normal range, then you have to add HCG. HCG, HMG 75 international units every alternate day. Then it has to continue till we see some sperms in the ejaculate. And we are not supposed to wait for natural pregnancy in these patients. If we see some sperms in the ejaculate, then immediately we have to freeze and we have to plan for IVF, because we should not give them, because this is an expensive treatment. We are not supposed to give them false assurance that they can have natural pregnancy. If they are ready for IVF procedure, then only it's worth taking that risk and giving all those injections.
Correct, sir. And question to Dr. Rajan, role of agonist trigger in IUI cycle, and what is your preferred trigger in PCOD?
Yeah, my preferred trigger in PCOD PCOD patients, as I already stated, I have switched over to letrozole. My preferred trigger is still human chorionic gonadotropin, that is 10,000. Agonist trigger, yes, can be. Agonist trigger virtually has no role with the advent of letrozole. Agonist trigger used to be given when we had a step-down protocol. We didn't have the Legros's paper still yet published, and superiority of letrozole over clomiphene was not proved in those patients. I used to give an agonist trigger and give a very aggressive luteal phase support, because giving agonist trigger will definitely undermine the functioning of the corpus luteum. So this was prior to the era of 2014. But once we have letrozole in hand, I hardly ever have to give an agonist trigger. I give a traditional SCG trigger and perform the IUI cycle.
Right, sir. There is again a question to you only. What is
Yeah.
the dosage of cabergoline if restricted growth of follicle, and how many times and what dosage should cabergoline be given in spikers?
0.5 milligram daily, starting from the day you get the result till the ovulation.
So they are also asking, as you are never sure prolactin spiker, is it worthwhile using cabergoline once on day 5?
I didn't get the question.
So they are asking, as you are never sure of prolactin spikers, is it worthwhile using cabergoline on day 5?
No, you can't use it empirically unless it is proven to be a case of,
Yeah.
because spikers are around 10 to 15% of arrested growth population. Majority of them are because of LH hyper. I'm talking of PCOS. We are talking of PCOS cases only. Majority of them are because of LH hypersecretion. Spikers are around 10 to 15%. For treating 10 to 15%, we can't give the remaining 85% unnecessary cabergoline.
Correct, sir. Sir, Dr. Rahul Reddy, which antibiotics do you prefer and the dosage regimen of seminal vesicle infections?
It depends on semen culture. So most common organism in India, what we have found is Enterococcus faecalis. Second common organism is E. coli and Klebsiella. So if it is Enterococcus faecalis, simple ampicillin works very well. Ampicillin 500 milligrams BD doses for 15 days is best antibiotic for Enterococcus faecalis. If culture comes back as positive with same organism, then you have to put them on linezolid. If it is E. coli or Klebsiella, levofloxacin or ciprofloxacin will work.
Right, sir. And they are asking antioxidants you prefer in oligoasthenoteratospermia.
No, there is no particular antioxidant. It all depends. Any brand, whatever brand you want, you can use. And you have to, what you have to see is whether the patient is affordable or not. If patient is affordable, you can put them on coenzyme Q10. You can choose a combination which is coenzyme Q10, lycopene, astaxanthin, vitamin C, vitamin E. But if patient is not affordable, just put them on simple vitamin C and vitamin E. Even they are good antioxidants.
Sir, question to Dr. Rajan. Many times we don't see endometrial thickness is poor in letrozole cycles. How do you go ahead?
Endometrial thickness being poor in the letrocycle, I would not hold letrozole to be responsible at all, because letrozole has no peripheral antiestrogenic action. The other causes of endometrium remaining thin, such as chronic endometrial infections, the poor endometrial blood supply, past infections, treated infection, this will have to be investigated properly by doing proper history evaluation and even hysteroscopic examination. I would not incriminate letrozole at all as a cause of poor endometrial thickness, because letrozole doesn't act on the peripheral estrogen receptors.
Correct, sir. There is one more question to you. If there is no dominant follicle on day 8 with clomiphene 100 mg, what's the next step? Do you add gonadotropins?
If there is no dominant follicle on day 8,
With clomiphene 100 mg.
100 mg, no dominant follicle on day 8. You can't get dominant follicle on day 8 at all. Dominant follicle would be starting somewhere around day 10. So if there is no day 10, I would tell him to repeat the scan on day 10. If day 10 there is no dominant follicle, in that case, I would still do serum LH. If serum LH is less than 10, this is a very important take-home message. If serum LH is less than 10, then only resort to gonadotropins. And there also I will prefer a recombinant FSH rather than any biological preparation, because I wouldn't like to have any trace of LH activity. So the dominant follicle will be decided by day 10. If there is no dominant follicle by day 10, do a serum LH as I said. If it is more than 10, then we have to cancel the cycle. If it is less than 10, then give her a recombinant FSH and proceed with the cycle as you would proceed for an antagonist protocol.
Sir, role of corticosteroid in resistant PCOS?
No, I am. Yeah, it used to be given for patients who had high dehydroepiandrosterone sulfate levels. The results are very equivocal, and personally, I never favored it, so I never use it.
There is one question to Dr. Rahul Reddy. Will you please elaborate on testosterone estradiol ratio indicated science behind it?
So testosterone estradiol ratio is always 1:10, where testosterone is done in nanograms per deciliter. That means if testosterone is 4, estrogen, if it is more than 40, then it is abnormal. If testosterone is 2 and estradiol is 20, even then that is normal. If it is 25, then it is abnormal. So it should be 1:10 ratio.
Correct, sir. And what are the causes of delayed liquefaction, semen liquefaction, and how do you manage it?
So see, again, the most common cause for delayed liquefaction is prostatic infection, because most of the time, because of the chronic prostatitis or chronic inflammatory conditions, the prostatic proteases will be deficient in the ejaculate. This is the common cause for delayed liquefaction. So in all these patients with persistent delayed liquefaction, we have to see whether this is treatable or not. That means if it is active infection, we can treat. That means if semen culture is positive, then we can give antibiotics. If there is no active infection, that means even after giving antibiotics, if there is persistent delayed liquefaction, these patients are these are right candidates for IUI, because a natural pregnancy may not happen because of delayed liquefaction. So now in these patients where semen culture is negative, but there is liquefaction continues to be delayed, take them for IUI procedure. But if infection is positive, keep treating the infection.
There are so many questions, and they are complimenting you both for the very good lectures and giving them practical tips. But last question to Dr. Rahul Reddy: any medical treatment for non-obstructive SU before retrieval?
Yeah, definitely. As we said, testosterone is important for sperm production and maintenance. So most of these patients, non-obstructive spermia, you find a typical finding where FSH, LH is on the higher side and testosterone is on the lower side because of poor testicular function. Here, we have to put them on HCG injections to normalize testosterone levels, and then do a testicular biopsy. Because there is no point in doing a testicular biopsy or TISA procedure without normalizing this testosterone levels. That will increase the yield of sperm retrieval.
Correct, sir. And how long practically it goes, the medical treatment?
No, till the testosterone normalizes. If it normalizes in, say, ideal scenario is two spermatogenetic cycles. That means 2 spermatogenes, each cycle is around 74 days. We can try up to 5 months time. Correct. Even in normal patients with oligospermia, you can treat them for 5 months time. If it is not improving in 5 months, that means they're not going to improve.
Correct.
So that is why when we see a patient who is already on treatment for months together, there is no point in giving one more antioxidant and waiting.
Correct, sir. And the last question to Dr. Rajan: how do you manage thin endometrium in IUI cycle?
How do I manage thin endometrium in an IUI cycle? As I said, no exogenously given. I presume the patient has had a proper workup before, and the other causes of hyperprolactinemia, etc., has been ruled out. We have no exogenous amount of estrogen, howsoever large, is going to help her. We have to counsel the patient. No need to cancel the cycle. I have got pregnancies with the endometrium as thin as even 6 millimeter. So no need to cancel the cycle. Counsel the patient that the pregnancy rates will be undermined, and then she should be recruited into the luteal phase clomiphene start protocol in the next cycle.
Thank you, sir. Thank you, Dr. Rajan. Thank you, Dr. Rahul, for giving us very insightful lectures. All the viewers are giving compliments to you. I thank you on behalf of them and on behalf of Intas.
Thanks everyone. Thanks to the organizers for having us on your panel.
Thank you.
Thank you, Dr.
Thank you, Satpal. Thank you.
And I'm sure all those 710 delegates who registered for this webinar has got a nice take-home message. I would like to thank Russell for beautiful deliberation also. And last but not the least, I would like to thank Rajiv and Anup from Cooper Surgical who collaborated together. Thank you all, and thank you for sparing your time, sir, and our invitation. Thank you very much.
Thank you.
And thank you, Dr. Sonal, for moderating this session.
Thank you, sir.